Hi, welcome to this week's Telehealth Secrets webinar. My name is Anne. You can't see me, but I just have a few quick housekeeping announcements before we get started. So the session will be recorded and will be made available in a couple days right after this webinar. Please submit your questions via chat as you think of them, and we'll try to get to them at the end of Sean's presentation. Also, his slides are in the handout section if you're having trouble seeing, or if you want to grab the slides now. And also, we'll also be having another, if you're interested in online counseling and getting started in online counseling for telemedicine, we'll have Roy Huggins, who's at Person-Centered Tech, talking about that on June 11th. So with that, let me do a quick check. If you can hear me, can you raise your hand? So there should be a hand raising. If you can hear me and if you can see me, or not me, see the screen. Let's get some hands. Okay, I think most people are hearing fine. Okay, so let me go ahead and pass the time over to VSee CEO, Dr. Milton Chen.
Thank you so much, Anne. Welcome to this week's Telehealth Secrets. Really, thank you so much for attending. My name is Milton, I'm the CEO of VSee, and I'm super excited to have Sean as our guest for this week in there. So Sean's the director of virtual care for the VA Portland healthcare system. So he's been doing telemedicine for over 10 years. And he had done a number of projects at the VA, including things like telejustice service, enabling justice-involved veterans lodged in the county, state, and the federal correctional institution to access the VA healthcare and benefits. And some fun facts about him is, so Sean has a deep heart for improving the access of mental health resources and also reducing the stigma associated with the mental health diagnosis. He has done a lot of volunteer work for the local chapter, NAMI, the National Alliance on Mental Health. And in fact, another thing really interesting about him, he actually works regularly with Dr. David Shorkin, the former Secretary of Veteran Affairs. And he was a person behind the scenes who set up the telehealth demo when the President Trump and Dr. Shorkin unveiled the 2018 telehealth initiatives for the VA. Again, so I'm really honored, privileged to have Sean here with us. How about Sean? Maybe I'll turn the floor to you. I know you have some thoughts you want to share with us, and then after that, we're just going to open up for the audience to,
sure.
ask you questions.
Can everybody hear me? Excellent. Okay, so I have prepared a slide presentation, so I'm gonna start that slide presentation. And okay, can everybody see the slideshow?
Right now, I just saw the slideshow. Now I'm seeing the slide presenter. I see like next slide and the current slide.
Okay.
Okay, now it's good.
Excellent. Okay, so basically I'm just going to talk today a little bit about VA telehealth and the COVID-19 response. I'm Sean O'Connor. I'm the Director of Virtual Care for the VA Portland Healthcare System, which is a fancy way of saying I manage telehealth for the VA Portland Hospital. Basically, today we're going to talk a little bit about the VA telehealth response from a large perspective, but most of the things I'm going to share today are specific to our VA Portland healthcare system and the VA Northwest Health Network, which comprises the Pacific Northwest facilities in Alaska, Washington, Oregon, and Idaho. So just a little bit about me. I began engaging in telehealth when I was a lab technician at a community-based outreach clinic, or a CBOC, at the VA. And there was a need for somebody to be kind of the video conferencing technical support person at that CBOC. So I got very involved in video conferencing and clinical video telehealth at that time. This was prior to the T21 initiative, which then expanded telehealth capability across the VA, instituted by, at the time, the Secretary of the VA, Dr. Mr. Shinseki. From there, when they started hiring positions, I became the lead teleclinical technician at the VA Southern Oregon Rehabilitation Center and Clinics, which is in Southern Oregon in a town called White City. So at that time, I got extremely involved in telehealth program development and telehealth technology. So I configured, deployed, maintained a lot of telehealth technology and equipment. I also spent a significant amount of time training individuals on teledermatology imaging and clinical video telehealth, and traveled to a lot of different sites in the country to train new VA telehealth staff. After doing that for a little bit, I moved to the network level, which is the VA Northwest Healthcare Network, as the Network Telehealth Technology Manager. So I oversaw telehealth technology for 8 VA healthcare centers in the Pacific Northwest. And during that time, I was also detailed for a period of 1 year to the central office telehealth department as the National Technology Manager to work on advancing telehealth solutions for the VA. Recently, I just took over as the Director of Virtual Care for the Portland Healthcare System. I oversee telehealth programs for over 60 different clinical specialty areas. I also oversee home-based video telehealth services, store and forward telehealth services, secure messaging, and the Annie app, which is an app that allows clinicians to send text messages to veterans in response to specific disease protocols, such as hypertension, congestive heart failure, diabetes. This is not kind of a free text system, but it does send prompts via texting to patients for them to respond with specific biometric data. So telehealth at the VA Portland healthcare system. So what's interesting about Portland is that we have significantly been at the forefront of telehealth innovation since 2009. My former boss and friend, Dr. Peter Shore, was the first VA clinician to deliver telemental health services to veterans in their home. He developed a pilot project, which then became a research project, looking at how to keep veterans from having to travel to a brick and mortar facility and sit in front of a teleconferencing unit when they could just as simply be at home in a more welcoming and comforting environment while performing telemental health services. This pilot was successful and then basically became, just a general practice within the mental health department here at Portland. And eventually that pilot served as the framework for the expansion of home-based video telehealth services within the VA itself. In 2012, Dr. Shore and I worked on a project called VA Innovation 669, which we had determined that home-based video telehealth and home-based telemental health was a valuable service, but we ran into a lot of veterans who simply did not have access to the technology to participate in this program. So we worked on basically two fronts. We worked on the use of technology devices that could be loaned to veterans so that they could participate in home-based telemental health services, and also the use of alternative video conferencing technologies to ensure that we were delivering the highest quality video service to our veterans. Part of the research that we conducted was taking a look at how access to technology decreased the instances of social isolation for people with mental health diagnoses, whether or not the use of technology helped folks with mental health diagnoses feel more socially connected and enabling, and did this technology enable individuals to feel more comfortable in managing their own health care. Also, some innovations that we participated in are the Telejustice program. We've delivered services to just involved veterans to assist them in gaining access to VA benefits, such as disability compensation, community reentry, so incarcerated veterans preparing to reintegrate into the community post-release, Enrollment for VA healthcare services, so veterans that are incarcerated that may not be enrolled in the VA to receive healthcare or benefits, we assist them in getting enrolled. And also for mandated court appearances for Veterans Court. Home-based video telehealth. This is kind of specific to the COVID-19 response, and as we all know, in early 2020, our country was stricken with the COVID-19 virus, and this kind of very rapidly ramped up in areas of infections and deaths. Of note, some of the more severely impacted populations were veterans in residential or inpatient settings. Hospitals and veterans homes, community living centers, rehabilitation centers were some of the hardest hit, along with community nursing care facilities and residential facilities. So these are extremely high-risk individuals, extremely high-risk population, and we really need to make sure that we're giving them as many services as we can while eliminating the risk or reducing the risk of them becoming infected. In addition, later in an emergency response to the virus, states, including all states in our catchment area, have issued stay-at-home orders and closed many local businesses. Access to healthcare services within the VA have been extremely limited due to the fact that we are only seeing medically necessary patients, sorry, I've drawn a blank here. Non-essential services, non-essential surgeries, and non-essential procedures have been put on hold at this time, and most veterans are receiving their care through virtual means such as video conferencing or a phone call. So because of this need, the VA has increased the use of home-based video telehealth services so that veteran patients can continue to have clinical visits with their clinicians while remaining in a safe social distancing posture, so not having to go out of their homes for unnecessary reasons. So due to the decrease in demand for home-based video telehealth, the VA has also temporarily authorized the use of non-VA video conferencing technology. Let's talk a little bit more about that. Because of the extreme reduction of face-to-face visits, the VA has increased its use of the existing VA Video Connect platform. So many face-to-face visits are transitioned to virtual means, and approximately 20-25% of our visits here at Portland are conducted using VA Video Connect. Of note, from the month of January 2020 through the end of April 2020, we noticed a 225% increase in the number of patients that have been seen using home-based video technology. VA Video Connect is the VA solution for video conferencing with veterans in their homes, and this uses virtual meeting rooms to connect veteran patients and clinicians securely and privately. So web application developed by VA Mobile Services enables us to schedule a VA Video Connect session. Once that is scheduled, the veteran and a clinician receive an email notification of the session, which includes a hyperlink to join the virtual meeting room. Both participants click on the hyperlink, they join the virtual meeting room, enable the camera, microphone, and speakers. Once they are both in the virtual meeting room, the clinical visit commences. I'm going to apologize because I'm already noticing a few typographical errors in my presentation. So some of the challenges with COVID-19 and the VA Portland healthcare system is that while we have noticed that VA Video Connect is a viable alternative for veterans in their homes, we have identified inpatient and residential areas where VA Video Connect was not the most effective solution to connect inpatient veterans and clinicians. This is simply because the mechanism of scheduling and connecting to the virtual meeting rooms is not available on a highly mobile basis and is limited to certain devices only. For example, we have deployed iPads to our residential and inpatient areas. However, these iPads do not typically have a email address that we can regularly send virtual meeting room information to. So we have identified a need for a point-to-point dialing video conferencing mechanism to reach our inpatient veterans and our residential settings. So clinicians indicated on a large scale that they would like to continue to hold clinical visits but not enter these the patient rooms in these inpatient areas and these residential areas. This may be due to not wanting to be exposed to COVID-19, not wanting to expose the patient to COVID-19, or not wanting to basically force a clinician or a veteran to travel in order or move to a different location or to receive a visit. So we also identified community living centers and state veterans homes where they had a need to conduct visits that would traditionally only be available by clinician travel, veteran travel, or phone. So we have one community living center that is located in Vancouver, Washington. However, Portland healthcare system covers a very large geographical area, and that is many miles from of some of our clinical care areas. Additionally, we have 2 state veteran homes, which are geographically distant from the VA Portland hospitals. So the need to provide specialty care to those areas traditionally has involved veteran transport. So in the situation that we find ourselves in now, transportation of elderly veterans does put them at an elevated risk of infection, and something we want to avoid. So due to this challenge, our healthcare system, a director of our medical center, has approved the use of VSee, which is a product that we are fortunate enough to have representatives, and they are hosting this webinar in order to connect these veterans to clinicians quickly, easily, and securely. So currently we're using VSee to connect to inpatient residential areas. This enables us to reduce the COVID-19 exposure risk, reduce the amount of PPE used in our inpatient areas, maintain the integrity of isolation areas and exposure risk protocols, and quickly and easily connect clinicians to veterans without the need for prior VMR creation and email system notification. With the clinicians we've used this so far, this more quickly and efficiently enables us to make a connection to the veteran, which reduces the overall time burden of the visit. Something I didn't put in the slide that also is kind of a benefit is the time required for technical support and training with VSee is significantly less than we see with other video conferencing alternatives. So currently we're using VSee to provide wound care services to inpatient residential veterans. We're providing infectious disease services and podiatry services. We will be expanding to pharmacy services for discharge medication planning beginning next week. We're working to expand inpatient video connections using VSee to other specialty areas, including cardiology and some other disease systems. I think we talked about pulmonology. I think we talked about some operative care situations. So it's an ongoing conversation, very fluid dynamics, and it's kind of a work in progress. A lot of shooting from the hip here. We are not currently using it to connect with veterans in their homes. We are pretty much exclusively using VA Video Connect. However, there are alternatives which have been temporarily authorized by the VA, which are being used, such as FaceTime, Google Duo, Skype, and Facebook Messenger. Other telehealth use that we've been successful with. So we've been using home-based video telehealth to conduct dermatology assessments since traditional clinic-based Thornford services are not available. This is essential for us to be able to provide a high-definition quality video visit, as we are looking at dermatology conditions, and the need for high-resolution image is critical in order to make effective treatment management recommendations. We are also currently piloting a Thornford process that enables veterans to take an image of their dermatology condition. They email these images to one of our telehealth clinical technicians who would traditionally perform the imaging in clinic, but now will not be. But they have the rights and permissions to upload those images to our electronic health record and then submit the request for our teledermatologist to review and make treatment recommendations. We also currently offer home-based video blood pressure visits, which enable nurses to assist veterans with hypertension and other blood pressure related issues to monitor and help them control their blood pressure. So traditionally, with the use of vitals, we're not allowed to enter those vitals that are remotely sent to through remote patient monitoring mechanism. We're not allowed to enter those as an official vital set in our electronic health record. However, if a nurse can visually verify that a blood pressure has been performed correctly and can view the results, whether it be in person or over video, then these blood pressure readings can be entered as vitals in the electronic health record. Another program that we've used is Telejustice. So currently our healthcare system and other medical centers within VISN 20 are using video conferencing technology to enable veterans that are in a residential treatment center to attend mandatory court appearances for Veterans Court, and they are doing this via video. This has been highly successful. We currently have that established in 5 counties in the state of Oregon. We're looking to expand it to counties in Washington, Alaska, and Idaho. And so far has been very successful. However, limiting factor is the fact that we have to be able to connect to the video conferencing system of the circuit court. Due to their security recommendations and their security posture, we cannot use our VA provided product, as their firewall will just not allow it at all. We have conducted compensation and pension evaluations to evaluate veterans for disability compensation to veterans that are incarcerated in correctional institutions. We also have veteran justice outreach specialists who provide social work services to assist veterans in reentry into the community after their release. They provide these services to veterans who are currently incarcerated in preparing them for reintegration into the community. We also have a program called Healthcare for Reentry Veterans, veterans who are incarcerated in a correctional institution who are looking at their release and may not be enrolled in healthcare for the VA or enrolled for VA benefits. So our HCRV specialists assist those veterans in accessing VA healthcare benefits, other disability benefits, housing resources, substance abuse treatment resources, and any other needs of the veteran. That really concludes my presentation, so I'm going to accept any questions now. I know there are probably quite a few questions, but I would be happy to entertain those now.
Sean, great. But thank you so much for that really wonderful presentation. I think that we all hear about the VA, like all the news, and it's nice to get a peek inside in there. Let me apologize. This pull up my notes. I guess maybe I could start out with questions. So like a few years ago, so VA started covering this to provide outside of the VA healthcare system to ease the backlog. So what are the cases that this is allowed? Like specifically, maybe I'm asking, like let's say I'm a private physician or counselor in there. I want to be able to provide services to the VA. Like how do I become part of the program?
So the VA, does partner a lot with private, physicians and clinicians and services outside of the VA. For example, we have a lot of areas that are rural here in the Northwest network, and this kind of started originally with audiology services. So veterans that suffered, hearing loss due to their time in the military. As their age advances, they have the need for hearing aids. Well, a lot of our medical centers and pretty much all of our community-based outpatient clinics did not have the ability to provide hearing aids. So we contracted with local audiologists to provide hearing aid services.
Okay.
There is an agreement, of course, that needs to be entered into with the VA. I'm not entirely sure what that contract process is. However, I am a close personal friend with a local audiologist where I came from in Southern Oregon, and his experience was, well, it was a little bit less than desirable, and he was not entirely pleased with it. Thankfully, since then, the Veterans Administration has enabled veterans to seek healthcare outside of the VA system where they may not be able to receive timely access to services because of VA backlog or lack of providers. Initially, this was called the Choice Act, and most recently it was called the Mission Act. I'm not entirely sure of the nuts and bolts as far as how does a private physician engage with the Mission Act as a approved provider, but I do know that there are resources for interested providers to become an authorized provider for the VA Mission Act. Those should be available on any public-facing VA website.
Okay, great. I think some of those practical, I know a lot of audience members, they're actually providers. Is always, I think any of those insights would be great. In fact, maybe for the audience member, we'll get in the appropriate URL. We'll post down there. So we have a question from Linda in the audience member. So she's asking, so how are the VA services reimbursed for the telehealth?
So we do have a specific section dedicated to the reimbursement for Mission Act or non-VA care, and we have basic offices and representatives located all the way from the central office level all the way down to the facility level. I don't know the exact reimbursement schedule. I have heard that it's and maybe recently they may have increased it above the Medicare rate, but during the Choice Act, it was at Medicare rate or slightly lower. I think with the Mission Act, that did include, or that did increase the amount of reimbursement. But I can say that it is not as simple of a process as I think most medical offices would like it to be. Okay. But there is a reimbursement structure, and there are individuals in the VA that focus specifically on this, and this is usually through a third-party administrator.
Okay, got it. Okay. We have a question from Neil asking, so what is the VA doing to protect the employees of the VA from COVID?
Certainly, yeah, that VA employees are definitely at risk because we're traveling around to a lot of inpatient areas. It's not just our ability to maintain mitigated risk strategies for our veterans, but also for our staff. So there are definitely a few strategies we have followed. We have authorized teleworking in a lot of situations. I have about half of my staff teleworking. At all VA healthcare systems currently, anybody in a direct patient care area must wear a mask and a face shield or goggles. In any public area of VA medical center or clinic, individuals are required to wear masks. The only time masks are not required is if it's in an individual's in an office by themselves, such as I am right now. However, if I were to have one of my staff come into my office, we would both be masked at that point in time. We also have instituted a testing protocol for our employees. So we have randomized testing of employees. We do have contact tracing for employees that have been identified as COVID positive, or in instances where a veteran may show up as COVID positive, we do contact tracing in an effort to determine any possible employee exposure. We also have several factors from our infectious disease and our employee health department that will work to ensure that quarantine procedures and employee safety is maintained should they be exposed to COVID-19. Additionally, we do have a strategy to limit folks with compromised immune systems or other healthcare complications, or we do have individuals that are over the age of 65 or 55 that work at the VA. So for volunteers, this is especially kind of an important population because a lot of our volunteers are elderly. So a lot of our volunteer services have been temporarily discontinued, and then we're using strategies to make sure that folks with comorbid conditions are not exposed, whether we limit them to a certain office area or allow them to telework. As far as individuals working under me, I've authorized them to telework.
Got it. That's really. How about in terms of like the provider actually dealing with the actual COVID patients in your hospital? Are you doing things to make sure minimize the exposure, to make sure they go from a COVID patient to a non-COVID patient, making sure that?
Yeah, we do follow CDC guidelines for all personal protective equipment, as far as when is it allowed to be used consistently, or when does that have to be disposed of or laundered, and when they have to apply personal protective equipment, such or VA issued equipment, VA issued clothing such as scrubs. So we are continuing to manage that. We discuss that on a daily basis. We also are trying to limit employee exposure to those areas, which is one of the reasons we developed an iPad program, so that we can deliver an iPad into this service or into the inpatient room and not have as many. So even nurses who may need to talk to the patient do not have to go into that room. They can simply talk to the veteran using an iPad. And of note, this is something kind of interesting. So we discuss things with our sterile protection services department, is how do we maintain cleanliness and cross-contamination risk with the iPads. What we discovered is that by simply using a Ziploc freezer bag, we were able to have a very effective contamination procedure that we can follow. Basically, we can disinfect the entire surface prior to taking it out of the room. Then we go to a clean area, we dispose of the bag, disinfect the iPad, and then charge it and rebag it. So very simple, cost effective. I was out there looking for dry bags. They're running from $20 to $80 a piece. Ziploc bags are a lot cheaper. So this was something I didn't even think of. This was our sterile processing service and infection control department. So very, very innovative.
That's really, I love these type of simple solution, but it's really effective.
Absolutely.
We have so Richard is asking, are you doing and monitoring the vitals other than blood pressure for these home base?
So we do currently have a mechanism that is still kind of in the initial operation capability phase, where one of our contractors is providing Bluetooth connected peripherals that can be viewed during a VA Video Connect visit. At that time, it is not something that we can directly enter into the patient record as an authorized vital entry, but we can indicate in the progress note that these vitals were observed. We also have our remote patient monitoring program, where nurses, individuals who've been assigned to a certain disease management protocol, receive certain peripheral devices and a set of DMP questions, which are entered by the veteran on either their hub or a web accessible version of the remote patient monitoring platform, or through interactive voice response. Those are entered into a dashboard that home telehealth nurses monitor, and when we see things that are outside of the normal range, home telehealth nurses will engage with the veteran and do some healthcare coaching in that respect. We do everything from congestive heart failure to mental health disease management protocols to weight management, and recently we have an approved disease management protocol for COVID-19 and other respiratory illnesses.
Great. Okay. So we have a question from David. So he's asking, so he's a physician in Minnesota. Could he provide service to your patient in the Portland area?
That is a very good question. We are still in the process of determining how our cross-state licensure will apply for VA services. So currently, as long as the patient and the provider are located in a VA brick and mortar facility, we do kind of have some mechanism for VA license portability. However, one of the challenges, there are a couple challenges when associated with alternative methods of technology. So for one is a physician in another state delivering services to a veteran who is located in their home. In that instance, we still have not completely figured out the legislation or the guidance for that. The other situation is, what if the provider is in an alternative work site? So we do have several providers that telework as a rule because of either space considerations or the fact that we have several hub and spoke models for delivering certain services. So teleworking is really the only way we can manage the ability to host a provider without providing them VA space. So Some of this is still in the works. Our National Telehealth Office and other central office individuals are working on this legislation, working on the guidance with Office of General Counsel, our credentialing privileging office, and then of course Congress. So still in the process. We have managed to find a way to ensure that the Riot Hate Act is adhered to for prescribing of controlled substances. It does require the veteran to be on VA premises and also the provider to be on VA premises, but basically all of our community outpatient clinics have been DEA registered as sites of care, not as prescribers, but basically DEA registered as receiving sites of care, enable us to remotely prescribe Schedule II substances.
I see. I guess in terms of like the outside of the VA in the general terms, so because of COVID, they have removed this, this for a license distribution cross state in there. Is there also a temporary rule applied to VA when that's not, is still like, you have to follow all the, okay, got it.
Actually, I think I just, so we are looking at, actually, if you'll excuse me while I pull up this reference document. We are kind of looking at telehealth clinical resource sharing between VA facilities and telehealth from improved alternate work sites. So I have not completely reviewed this, and we have not engaged with our executive team here at Portland yet. But I think if we're talking about VA healthcare professionals acting within the scope of their VA employment who have met the alternative worksite requirements may furnish healthcare services using CVT from an approved alternate worksite to serve eligible beneficiaries. This directive, however, does not apply to VA contract healthcare professionals.
Okay. Interesting. Okay, yeah. Hopefully they can have loosened out the regulatory, at least to provide the service, and then later on they sort out what the.
Yeah, I'll just type a message here for anybody that is interested in reviewing that. This is VHA Directive 1914. You should be able to access that from va.gov forms.
Okay, terrific. We have a question from Susan asking, what are the type of response are we receiving specific from the seniors in the VA community centers? Do they feel comfortable with these telehealth? Could they, like from laptop to tablet to mobile phones that they have?
Yeah, so here at Portland, we have basically a home-based video telehealth patient support team. So we do find with VA Video Connect that there is kind of an initial orientation and training phase that veterans should participate in just to get comfortable with the technology. From my team, I get regular reports as to the level of success. So how many times are we successful in enabling a veteran, and how many times are we running the situations? We do see somewhat of a correlation between age over 65 and difficulty in managing technology. However, it's not really as high as I would have originally thought. We do see a lot of folks that are somewhat familiar with video technology that are in an advanced age simply because they currently use some form of video technology or email or social networking to stay in contact with family members that are not geographically near to them. We also have quite a few people who are using smartphones or tablets simply because that's kind of what you buy now. It's hard to buy a flip phone anymore. Although if it were me, I'd prefer to go back to the flip phone. But we do notice that yes, advanced age, usually above the age of 60, 65 is when we start seeing a little bit more of kind of that technology barrier and technology access barrier. We also do notice that with advanced age, certain conditions are more likely to be present, such as dementia, tremors, other types of cognitive impairment. In situations like that, we usually have a caregiver that can support or that will support a veteran. If they don't have a caregiver, then usually it's not so much that we can't teach the veterans that they can't really retain the information because of some cognitive impairment. Another issue is, I brought up earlier in the presentation was veterans with access to technology. Veterans without access to technology do have a difficult time in engaging with home-based video telehealth. And a lot of veterans I've worked with individually and provided loaned iPads to, these are individuals that previously have only ever used a flip phone. So there is some training that needs to occur. But we do have teams designed to support those veterans and do as much as we can to educate them.
Got it. Is it okay to ask how big is your support team? Like how many people do you have like this?
Unfortunately, it's not as big as I'd like. Right now we have only about 10 individuals on our team. And so we really only cover our VA healthcare system. Currently, each of these individuals are working almost their entire 8-hour or 9-hour shift doing nothing but VVC support, video conferencing support to veterans. So it's pretty much all hands on deck right now. We're handling about 50 to 60 incoming requests per day.
Okay, got it. Okay, that makes sense. But one question I have is like when you have these sort of traditional meeting based in there, right? What percentage of the time the veteran ran into some issue, or maybe it just is appointment no show? Then in the end, then this provider have us like is this? I know the national average is about 18% physical appointment no show. When you do virtual, do you find similar or like better or worse?
So the way that the VA handles scheduling, because of kind of our internal architecture, it is a little bit difficult to take a look at, what is a no-show and then what is classified as a no-show because of technology, failure, or just, what is technology failure and what is just, the patient just no-showed. So right now, from what I'm getting reported from different service lines, this is just a relative ballpark, but so I don't have any hard data to back this up. So it's just anecdotal evidence. Is we're noticing about a 25 to 30% rate of having to convert from a video appointment to a phone appointment because of technology failure. Our no-show rate does not typically be any higher than our no-show rate for face-to-face appointments. But what we don't know is how many of these individuals did not present to the virtual meeting room because of technology failure, and then there just was not time to try to contact the patient, or not an effort to contact the patient to see if they were having technology failure, so the appointment was automatically no-showed. So that may, or basically the individual was not able to be contacted because their cell phone or whatever was tied up. So we haven't really seen a no-show rate that's any more prevalent than our face-to-face no-show rate, but our technology failure is running right about 20, 25%, 25 to 30. It depends on the service, and it also depends on the location of the veteran.
Sure. Okay. We have a question from Jenna asking, so right now that since the VA approved using like Skype, like FaceTime, these tools, I'm assuming VA is not doing anything beyond like just the normal consumer offer to ensure the confidentiality, the HIPAA side. Are they just waiving these like for now?
So right now, the Chief Information Officer for the VA has authorized us to use alternative video conferencing technology. There has been somewhat of a posture of taking a look at HIPAA and trying to make a best effort to ensure that patient privacy and security is maintained during these visits. Personally, I can't really speak as to what goes on at other facilities, but in our facility, prior to, obviously cannot control what providers do on their own, but the instructions I have basically kind of pushed out to our facility leadership is if a alternative video conferencing technology is being used, just kind of reach out to me so I can do a security and privacy assessment and the appropriate research to determine security and privacy or any potential risks using that video conferencing technology. As a result, there are some video conferencing technologies that I have highly recommend not being used. I won't go into any names, but we do a security and privacy assessment.
Okay, got it. That makes sense. So for a question from Richard, he's asking, in the current VA system, do you also allow like a 3-way video connection? That means sense you could have a family member maybe to join this part of the.
Yes, we do. We can support additional caregivers coming into a session. We also hold group visits. Right now, due to our display constraints within our VA system, we have one presenter and 5 individuals. Otherwise, we cannot display more than 5 participants due to the way that our video conferencing is set up. And we do not want to run the risk of something physically happening to a veteran when they're not being displayed on the screen. So right now, we limited group of 1 individual and 1 presenter, 5 participants.
Got it. That seems to be more than sufficient from our experience. At most, you might need like a family member, maybe interpreter if necessary, maybe even not. That should be fine.
Yeah.
So I have a question from Craig. He's asking, so in the veterans and residential areas, is there always a medical specialist on hand that can sort of facilitate these sort of virtual appointment? Or this is really to expect the veteran to be more like a self-service?
Yeah, so our position here, within the VA Portland healthcare system is I will train somebody who's a VA staff member, or whether it be a CMA or a nurse or somebody of that nature who can assist the veteran. Typically, we do have somebody who does go into those patient rooms to take care of the veteran. And what we want to do is only have the fewest amount of people entering the room as possible. So we don't want, the CMA or the CNA or somebody like that walking in, and then a provider walks in, and then a nurse walks in. We want to limit that. But typically we do have somebody who is kind of providing, from lack of a better word, telepresenter services for the veteran. The only time we really do not use an individual such as that is for veterans who are technologically capable and simply using video conferencing to communicate with their family.
Okay, got it. So we have a question from Bruce. Are you guys planning to use like telehealth for dental emergencies?
Yes, we actually are. We are currently running a program where we're trying to do some teledental services between our community-based outpatient clinics and our dental departments, which are usually only located at a main hospital. However, that has since been put on hold because we are really run in a restricted entry for our dental department. This is really for assessment only, so maybe some assessment of a condition, possibly some pre-procedure evaluation and some post-procedure evaluation. We're also looking at, and this is the request of our Portland Dental Department, some tools that we can use that maybe we can send some type of intraoral camera to a veteran that they can simply plug into their device and then do these types of visual examinations using the camera in their homes.
Okay, got it.
We're kind of still in the planning phases. We're in a modified implementation phase that has been put on hold as far as our clinic-to-clinic teledental.
Got it. So Sean, like right now you're doing a lot of these really innovative services. I think you're probably definitely on the leading forefront of the VA to do all these things. To what extent you can make the decision like locally versus you have to go to the federal national level? Like, is this something where you need to get everyone to buy in the big and say, well, you can just say, here's a great idea, let me implement Tesla.
So that really depends on the resources needed to develop innovation. If it is a resource that is something that is we can locally acquire, go through local contracting processes, and we're basically just establishing maybe a new type of program deployment or program delivery. That is something we can do at the local level. I will say when I first started in telehealth, there was a tremendous amount of ability to innovate, earlier. The longer I've been working in telehealth, the more restrictive innovations is related to technology have been available within the VA. So if we're talking about alternative technology, usually I have to seek some type of approval from the national office in the use of telehealth technology. Now, if there's an instance where a memorandum or a policy has been sent out that allows us to use it, and I don't need to seek alternative approval or higher level approval, then we do implement services. As far as using specific types of hardware, this all depends on whether it requires software, doesn't require software. So if we receive, if we want to pilot a piece of equipment that is FDA cleared, it's cleared by a local health technology management department, and our local OIT department meets all the requirements of VA Handbook 6500, which is our electronic security, privacy, everything kind of handbook. Then we have a little bit more ability.
Okay. Okay, then something, because I think the reason part I asked, I think probably most of the audience members, they'll be looking where figure out to able to serve VA, whether as a provider or as a technology vendor, try to figure out where to.
I mean, right now, from a national perspective, we do have to maintain, our VA contract requirements, and we do have quite a bit of telehealth products that, have been approved and are, currently in use for VA telehealth. But if we're taking a look at, perhaps some type of feasibility study, once again, it's really highly dependent on what we're looking to test.
Okay, great. So I have a question from Susan. She's asking, so now that you have done a bunch of these for telehealth already, what are some additional areas you actually plan to expand for telehealth?
So one of the areas that I feel we have the potential to expand in is expanding telehealth services to non-VA partnerships. So we have been successful at some correctional institutions, jails, courts. There are certain instances in pilot phase that we've been able to establish telehealth services with certain veteran service organizations. Currently, there was a project, I don't know if anybody has seen that, it was called Atlas. It's where we actually set up kind of a pod in a veteran service, it was a veteran service organization. I can't remember if it's VFW or Disabled Veterans America, but they set a pod up. We have partnered with other agencies where we simply set up a kiosk device in a private location. And then basically a veteran will go to that location, use the iPad kiosk device to connect back to the VA veteran. We have partnered with educational institutions, so community colleges, state universities, state colleges, where we use either their technology that they have on site, or we provide some type of loaned kiosk that they can put in a location so that veteran students can access VA healthcare services. So increasing our partnership with non-VA locations is something we're definitely looking to expand, and something that we're trying to target with in institutions and areas where there's a high percentage of veterans. So really trying to reduce the travel burden or some of the cost burden that may be associated with traveling to a VA healthcare center.
That makes sense. But Deshaun, when you provide the services in there between, let's say, a veteran living in some residential, versus living in the private homes in there, is there a mixture? Like, what percentage are in you provide service to the resident versus like just in their home?
Yeah, that's actually not some data we've been able to really find very easily right now. I have started working with our state veterans homes to be able to kind of get an idea of what those services are, but right now we don't really filter down to that level. It's really just okay, who's the veteran and what services do they have. However, moving forward, I do have some plans as far as how are we going to prepare reports, how are we going to monitor and track kind of the overall numbers of who is utilizing these services.
Okay.
So right now it's very non-granular, but hope to be able to drill down a little more significantly in the future.
Got it. I think the part that I was asking about that is, so David asked the question is, are you guys working with these local home health agencies to able to provide service to the veteran? Because now you have someone who can physically go into someone's home, that maybe help them where they set up their iPad to do a call or what. So.
That I really couldn't speak very well to. I don't really know what the involvement is as far as what home health agencies that are contracting with the VA are allowed to do and not allowed to do. Typically, once we contract something to an outside provider, there kind of is that really clear division between what we do and what they do. I would like to see maybe a little more partnership and co-managing of care, but right now I don't know enough about those types of programs to speak to what would be available and what would be possible.
Yeah. So Sean, we have a question from Sophia asking, so from your experience, like what are the main challenges of like just doing the telemedicine for the veterans? Like, do you have like a top three? I know there's a lot of them, but what is the
So
biggest?
telemedicine with the veterans, I see that the biggest barrier is ability to use technology.
Okay.
So when I look at developing a program, I really try to make it something that is simple and is easy to use, that somebody who may not have a whole lot of familiarity with technology can access it in a reasonably easy method. I think that what I consider easy is definitely not what somebody who has only used a flip phone or never used a mobile device would think is easy. So what I try to do is I try to get identify those populations, work with them to determine, okay, how would this be the easiest thing for them to use. So access technology is probably the top one. Privacy concerns, I think originally I thought this was going to be a larger concern, but it really hasn't been. Really hasn't been. So, the second most consistent issue is internet connectivity and bandwidth availability. So that usually is the limiting factor. If we have veterans that are able to use technology, maybe they don't have access, or their home internet service just is not of the quality that enables video to be as good as we would like it. And then third would probably be just veteran preference. I think that there's still a lot of veterans that would prefer to see their clinician face to face, and there is somewhat of a generational divide between who is more willing to try the use of technology and who isn't. So willingness to attempt to use the technology or try the technology is probably the third.
Got it. That makes sense. So we have a question for Anis. So what are the physician specialty that's really like maybe desperate needed from the VA? Either certain type of things you're like have a huge need versus other time you guys have a lot of capacity already.
Um, that really varies from site to site. It usually depends on where we have adequate staff and where we don't have adequate staff, and then geographical barriers that may prevent individuals from being able to access certain services. We take a look at the East Coast, where population is very concentrated. It may not be a very a significant geographical barrier to get to a VA medical center for specialty type services.
Okay.
When we talk about the Pacific Northwest, and then we go out to Montana, the Dakotas, maybe even Utah, we do see a significant geographic distance. And of course, we cover Alaska, so it's not just geographic distance. You can't travel unless you fly or take a ship. So that it really depends on the services as far as what is kind of needed. Typically, I would have to say probably the largest services that we see, if I had to pick the top three, would be cardiology, dermatology, and then kind of a mix between sleep medicine and pulmonary services.
Okay, that makes sense. We're coming at the end of the hour. Unfortunately, I apologize to the audience member. There's a huge list of questions we haven't gotten to yet. So probably we'll go again, send these questions to Sean. We'll have some written response, and we'll go again, push it back in there. And definitely, so feel free to reach out to us to any additional question there. Maybe as we try to wrap up, maybe I have just maybe rapid fire for Sean. It's like, if from the things, like from your presentation today, is there like only one thing you want to, like the most important thing you want to share with the audience member? What would that be?
One thing, I guess the most important thing I would want to share with the audience is that, I know that there are times, when there is this perception that maybe the VA is kind of failing in certain areas, and I can't really speak to every single VA facility in the nation, but what I can assure you that I've worked with the VISN 20, the VA Northwest Healthcare Network, and Portland, and all of our facilities, and we really do want to make sure that we're providing the best care to our veterans. And for me and my counterparts in other healthcare systems, we're really very passionate about telehealth. We really do believe in telehealth. And we really are devoted to making telehealth the best solution that we can, so that we can address the items that telehealth really makes things easier and efficient and more meaningful.
Yeah, got it. And the final question is, so supposedly you have a magic wand, so you can whisper a thought or idea into President Trump's ear that's specifically relating to the VA, something you want to change. Like, what is that, like one thing or you want to like just wave it, just happen, and President Trump will give an executive order?
Sure. Honestly, from my perspective, I mean, I do, I do have background in program management, systems redesign, systems analysis, but, I am kind of a technology guy. So if I had a magic wand and I were to, talk to President Trump and be able to get whatever I wanted, I would say that we should never limit our solutions for telehealth to one single solution. I think we should always have a main solution, a backup solution, and then a secondary backup solution. We should never be interrupting any type of services because one of our systems has failed. We should always have contingency planning. I'm a contingency planner, so I want to make sure that we do not interrupt services. So that would be mine.
Got it. Really appreciate it. Sean, thank you so much. We're really definitely honored
Thank you for having
me. Sharing the audience, just insight and wisdom on this. I really, really like. Thank you so much.
Yes, thank you, Milton. It was good to see you and good to talk to everybody. Thank you very much for your questions. And I'm sure that Milton will send me any questions I wasn't able to get to.
Great. Thank you.
Thanks, everybody.
Thank you.